Hello, everyone, and welcome to Henry Schein's series on COVID-19 on YouTube. I'm Dr. Gary Severance, and it's always my pleasure to welcome Dr. David Reznik, who's going to update us on the latest information regarding COVID-19, including an increase in hospitalizations, the return of masks in some areas, and information on the latest variant. Dr. Reznik, welcome.
Welcome. Thank you, Gary, for the introduction, and welcome to our July clinical update on COVID-19 and dentistry. It is always a pleasure to share some information, and we have a lot to share today. I think one of the points that I really want to make, and I've just been thinking about it, we have gone from, if you look at a weather map and you see the worst is thunderstorms or something even worse, hurricane kind of things, or perfect blue skies and sunshine, we have had a period of sunshine. We've really had a time to enjoy outdoors, do some fun things. But now, as we've heard on news in different areas, we are starting to see the BA5 and 4 cause us some concern. And so, to me, we're sort of at a cloudy level now. We need to be as careful with our infection control as possible. We need to make sure that in our offices that we really are protecting all staff, so patients should be masked when they come in. And we'll get through all of that as we go through today's presentation. The first thing that I want to cover, and I cover this almost on every presentation, is the community levels in all counties in the U.S. And when you look at this map is really based on how it's impacting the health system. So the number of admissions, the number of ICUs, and it's really related to hospitalizations and the stress that our health system is under. The advantage of the B4 and B5 is that they're milder diseases and they're starting to cause a little bit of an uptake in infections or in hospitalizations, but nothing like we saw in January. In January, we were in the middle of a bad thunderstorm where hospitalizations went way back up. They've gone down and they stayed relatively flat. It just depends on which part of your country. You can see there's more of a stress on Florida, more of a stress on Louisiana, and some areas of California and up north where people are doing vacations, I would imagine, at this time of year. But the community transmission levels are different. So this gives you an idea of the stress on the healthcare system. And I'm going to go into another slide later that really shows you a little bit more information. So the COVID Tracker recommends uses of this for community levels to determine the impact of COVID-19 on communities and on health systems. CDC also provides transmission levels, and we're going to go over transmission levels and what that looks like in a short period of time. And healthcare facilities use transmission levels to determine infection control interventions. I'm going to repeat that and say dental offices should use transmission levels to determine infection control interventions. However, as you know, I've worked in HIV for quite some time, and we treat every patient as if they have a bloodborne pathogen. And I know in your offices, you treat every patient as if they have a bloodborne pathogen. Due to COVID at the present time, we have to assume that every patient has COVID because there's so much asymptomatic disease, there's so much pre-symptomatic disease. So we really do need to protect our staff, our patients, and everything that we have been doing in the past. I know that there was a recommendation from an organization I happen to be a member of that leaving the decision to mask should be up in the waiting room, should be up to the dentist, to the practice. I feel a little bit differently because our waiting room is a part of our medical office. And so therefore, I think we should have masking in the waiting room. That's my personal feeling. That's what we do at my program. That's what we do at programs I'm helping around the country. And I hope that you will do that to make sure that our front desk stays safe, that our patients don't transmit to one another. We really just want to keep the safest possible environment. Remember, the whole key is how to provide the safest possible dental visit. If we look at some daily updates on cases, average daily cases, you can see the total number of cases in the U.S. is over 88 million. If you look at the cases on the average daily level, it really has sort of stayed flat in June, July. Deaths have decreased. There are now about 1 million, actually 20,000 total deaths in the United States, about 277 people per day, average per day, are dying of this. So it's not just a cold. I don't want people to think that this is just a cold. Hospitalizations, those numbers are on the rise. At Grady, when we were in June, we had our lowest numbers in quite some time. It was down to less than 10 patients in the hospital. We're now averaging about 50 patients in the hospital. So the numbers have gone up, but it's not the 300 patients we had in the hospital, or close to 300 that we had in January. And then vaccinations, the percent with their first booster dose is only 34%. And as I mentioned last month, we do have a vaccine hesitation problem in the United States. And so I'm going to talk about who should get boosted today as well. If you look at the age-adjusted rates of COVID-19 hospitalization by vaccination status, and this was from January 21, where we had Delta as a big problem, through May of 22, you can see that there was a big jump in the January, as we've talked about people that were hospitalized. The numbers have gone down, and the green line are for unvaccinated people. The numbers have gone down, but as you can see, they are beginning to tick back up. If you look at the preliminary series plus one booster, you can see that is much more protective than getting unvaccinated. So even though it doesn't protect you from getting infection, it does protect you from getting serious illness and ending up in a hospital, and you don't want to end up in a hospital. Rates of laboratory confirmed hospitalization by vaccination status. What we did was we looked at people who are up to date with COVID-19 vaccines. So up to date means that you, depending on your risk factors, you've had the primary series plus at least one booster. New recommendations are coming out, and we'll talk about who should get the fourth booster at this time. But in May 22, compared to people who are up to date with COVID-19 vaccination, monthly rates of COVID-19 associated hospitalizations were 3.5 times higher in unvaccinated adults. So you can look at 2.1 times higher in unvaccinated adolescents, 2.7 times higher in unvaccinated adults ages 18 to 49, and then 3.4 times higher for unvaccinated adults in my age range, and I'm still hanging on to that for a little bit, and then people just a year older than me are 3.8 times higher. So I got the initial two, I got my first booster, and I have received a second booster at this point. So did Anthony Fauci, and Dr. Fauci ended up getting breakthrough infections. One of the issues that we have with BA4 and 5 is their ability to literally bypass our vaccines. They can cause infection, and they can cause a disease, but you don't end up getting in the hospital. And I think that's a point that we have to go over. But our hospitalization rates have been increasing. And I think that's something we need to keep our eye on. The hospitalization rates are up 18% nationwide in the last 2 weeks, with a daily average of 37,000 plus people hospitalized with COVID-19 as of July 11. And this is HHS Health and Human Services data that was collected and reported by the Times. Southern states, as usual, have seen the greatest jump in the past 14 days, with South Carolina reporting a 54% increase in hospitalizations. Their daily average is 436 people. Arkansas with a 47% increase, daily average of 365 people. Alabama, 46% increase, daily average of 675 people. And Louisiana reporting a 42% increase, daily average of 420. So we are seeing some increases, and we are seeing some issues in all parts of our country. In California and the Bay Area, COVID-19 hospitalizations have reached their highest point since February, when the region was still coming out of the winter Omicron surge. The state is reporting a 28% increase over the past 14 days, with a daily average of 4,360 hospitalizations. California is a very large state. The CDC's latest variant proportion update for the week ending July 2nd showed Omicron BA.5 accounted for nearly 54% of all cases. Researchers from Beth Israel Medical Center in Boston recently found that neutralizing antibody responses against BA.4 and 5 were 24 lower than against the original strain. So again, this is more contagious. It doesn't cause more of a severe illness, but if you're not vaccinated, if you have underlying medical conditions, if you're older, this can cause hospitalization. So staying safe and staying careful is really what's important. Now, I have some concerns. Until the last day or two, we've had no warning about BA.5. It's been sort of silent. And now this morning when I woke up and I turned on the news, I heard people starting to talk about it. BA.5 has been around for quite some time. It is not something that just popped up yesterday. There actually is a relatively new strain that I will talk about that did pop up and showed up in the United States recently and is having a significant impact in India. We still refer to 2 vaccine doses as being fully vaccinated. And we know if you got 2 of the original vaccines, you are not covered unless you've been boosted. You really have a pretty strong drop, especially when it comes against BA.4 and 5. So you need to have the up-to-date needs to be important, but we're still calling people fully vaccinated if they've had those 2 shots. We have been told 5 days. That is all that needed for isolation when 5 days is the median length of infectiousness. So we're having people come back to work, or recommendation to come back to work after 5 days when they still might be infectious. And I think that's an issue. 1 in 4 people 50 plus have had the second booster. And that is causing a decrease in the survival benefits. So we really need to talk about who needs to get boosted. Healthcare facilities use transmission levels to determine infection control interventions. And that is something that comes from Dr. Topol, who's a founder and director of the Scripps Translational Research and professor of molecular medicine. So who should boost now? People who are 50 and plus should get boosted. People who are immunocompromised for any reason, and this would include uncontrolled HIV, oncology patients, etc. People less than 50 with multiple medical comorbidities. Frontline healthcare workers, that is us. We are frontline healthcare workers. Of course, we're taking all of the precautions in our offices. We're wearing our fit-tested N95s. Remember, we do that on an annual basis. We're wearing eye protection. We've been using PPE for so long in the dental field that I know we're doing the right thing. And so, again, it's fit-tested N95s. Make sure you do that on an annual basis. And there is for people who are asthmatic on your staff or maybe have COPD or difficulty breathing, the CDC does recommend that you can use an alternative form, which would be a level 1 to 3 mask and then a shield. Essential workers and planned travel places with high circulating virus. The people that can boost later are young and healthy. There are, as many of you know, there is work being done by all of the companies that actually it was Pfizer, BioNTech, Moderna, and Novavax were invited to the FDA to talk about what they can do to have boosters that will protect against BA.4 and 5. Those are not out yet, and they're not coming out for some time. So really, if you're under the category of boost now, please go ahead and get boosted now. I actually didn't do it at the hospital. I went to a local grocery store. They had a pharmacy there. I told them I brought my vaccine card. I told them I wanted I'm a frontline healthcare worker. I wanted my 4th booster dose. I got it, and honestly, I had no side effects this time. There was nothing there. So if you look at the community levels of transmission, how this impacts our hospitals. number of ICU beds, number of admissions. You see a lot of areas in the green. You don't see all that many areas in orange. But if you look at community transmission in all counties in the United States, we are red. We are very red. There are only a few areas in the middle of the country that have either medium or low levels of transmission. So almost all parts of the United States have high levels of transmission at the present time. A systematic review of 43 studies on post-COVID reinfections from 17 countries. Pre-Omicron protection was very high and durable, and I will show you that in a moment. Post-Omicron was substantially lower and declined more rapidly. So really, people are getting reinfected. We talked about earlier on when these older ancestral versions of COVID-19, Alpha and Delta, that you actually did get some level of protection, some herd immunity, and it would be hard to get breakthrough infections. But protection against Omicron is really waning, and we are seeing a lot of people getting reinfected. There actually is one person I've worked with who has been, not in the oral health center, but in the building, reinfected twice at this point. You're hearing all these people who have done the right thing, or, they've chosen, I shouldn't say done the right thing, they've chosen to be up to date with their vaccines, and they're breaking through. So again, taking the proper precautions depending on the environment that you're in will be healthy. If you're outdoors, I don't really think that masking is all that important. Because we have ventilation. If you're able to open windows, we have great ventilation. But if you're in a tight area, like say my office area, and I have an office full of people in here, everybody needs to be masked because we don't want to reinfect people or transmit. I think that's something we really need to be aware of. So remember that people really should have a negative test before they come back to work or before they see you as a patient. And we really need to ask about, have you had infection by Omicron on our medical histories, and when did you have it? I think those are important questions to ask. When we look at a closer look of what the Omicron subvariant BA.5 could mean for the U.S., what you can see is, again, a higher level of new cases per 100,000 people. This is the most transmissible variant yet. It's threatening a fresh wave of infections in the United States, even those who have recovered from the virus fairly recently. So you do get some benefit, but I'll be honest, I was at a research oversight meeting at the hospital yesterday, and the chief of medicine, who I have known for 29 years, got COVID. And it was really sort of surprising because he is infectious disease. I know he takes every precaution. I don't know where he got it from, but we're having cases in my building now where some of the social workers are turning positive. Some of the nursing staff are turning positive. We don't know whether it's coming in the clinic or it's coming from what people are doing at home. There have been no cases of COVID in the oral health center. We follow strict guidelines that if you're in the hallways, you're in an operatory, you have on a fit-tested N95. At my front desk staff, I'm allowing to wear KN95s. I know it's not really OSHA approved, but it does offer another level of protection. The subvariant of Omicron known as BA.5 is now dominant, according to federal estimates released this week. And together with BA.4, another subvariant are fueling an outbreak of cases and hospitalizations. And that's what you're hearing on the news. That's what you're hearing from me. But this has actually been going on for a little bit. Experts, infectious disease docs, researchers say the surge is being driven by the Omicron subvariant known as BA.5, which is especially good at infecting people, even if they've been vaccinated, boosted, and already had the virus. So it is that contagious. Is it going to put you in the hospital? Most likely no. Is it like having a simple cold? Not necessarily from the people that I've talked to. It's sort of like having the flu. So you really want to avoid getting reinfected or getting infected in the first place. It is highly immune evasive. That's why it is causing trouble. And it comes along in California at the same time that we basically have the delusion that the pandemic is over. That is not just in California. That's at the United States. And I understand it. We are tired of wearing fit-tested N95s in the oral health center. But I'm also not willing to put myself and my spouse and other members of my family at risk. So now when I go back into the grocery store, I'm wearing a KN95. I'm going to be honest. Do I get some strange looks? Yes. Do I want to get a virus that actually can infect me even though I'm up to date with my vaccines? I've not had the virus yet. Yes, it can. And I choose not to be put myself at risk. Being vaccinated and boosted, however, continues to provide strong protection against severe illness and death. And death figures for, say, California have remained relatively low in recent weeks, which is good, which I think is why there has been this, it's not that bad a thing. But remember, a significant number of people can get long COVID. It will infect almost 1 in 5 adults. And that colleague of mine who I talked about and several other colleagues, they've had long symptoms of just being exhausted. And so we really want to avoid this because we want to avoid long COVID, amongst other things. And the New York City is pushing an indoor mask advisory for all as the worst Omicron strain fuels the 6th wave. The BA.5 subvariant appears to escape immunity, as I've mentioned, escape and transmit more easily, leading some to call it the worst version of Omicron yet. It could be the worst version of Omicron, but by far it's not the worst version we've seen in COVID-19. A recent study of a severe outcome risk from reinfection raises fresh alarm bells. As I mentioned, people have gotten the disease, they recover, they're doing fine for a period of time, and then they get reinfected. All 5 New York City boroughs were added back to the CDC's high-risk category for COVID spread last week. Westchester County was also added to the list. What's behind the spread? Experts believe it's being driven by Omicron subvariants BA.5 and BA.4, which is 4.2 times more vaccine evasive than the predecessors, and they're also more transmissible. So it's evading even previous infection. It's evading being up to date with vaccines. And it is more transmissible. So that's why we need to be aware. Let's talk just a little bit about, since you can read what New York is doing on the right-hand side, let's talk about which masks provide the most protection. This is something just to help your patients and maybe your staff. A cloth mask, as we know, doesn't offer much protection. But any kind of protection is better than none. I'm seeing people who are now wearing a level 1 mask and putting a double masking and then putting some stylish cloth mask on top of it. That does offer more protection over disposable masks because you've created a more snug fit. Disposable masks are less effective than respirators. We've known that since the beginning. So a level 1 surgical mask that we might wear, we wore in the past, is not going to offer great protection. Again, that double mask that I just mentioned, a little style, a little flair if you're going to be putting these things on. And then, of course, the most protection are respirators, whether it's an N95, a KN95, etc. So in New York, they want to help the spread. So all New Yorkers should wear a high quality mask, such as, and this is actually a respirator, such as N95, KN95, and all public indoor settings and around crowds outside. More than a fifth of all U.S. counties are designated high risk for community transmission of the CDC, which is an increase of 70% in the last 2 weeks. In New York, Westchester County joined the 5 boroughs in their return to high risk, while Suffolk County was downgraded to a medium after just a 1 week of elevated risk. So these could be transient, but again, take the steps and offer the advice to your patients on what they can do to stay healthy. And you can have it as a general conversation. You could get this New York City map that I actually have that I borrowed from New York City's Department of Health. You can put that up in your office to give some idea of so patients are educated while they're sitting around waiting to be seen. The biology of BA5, again, there are many ways to get a sense of how distinct BA5 is compared to prior strains. Remember, I've always talked, the ones that we are really concerned is when a new variant of concern pops up. And BA4 and 5 are just subvariants of Omicron, so it really isn't a variant of concern. We can see how Delta was a big problem, how it caused a lot of hospitalizations, it caused a lot of death, and now you can see that BA4 and 5 are their own branch coming off of Omicron, but they're related to BA2, which is having more and more subvariants. So BA2 is what we're talking about. It's just the latest of the variants. It's not just the United States. Look at what has happened in Singapore, have already hit the second highest case peak after BA1. So you can look around January how high they were. It dropped down for a period of time, and now their numbers are again beginning to skyrocket. It's not just about cases, it's hospitalizations. So I know this is a very busy chart. Singapore is at the highest level here, followed by the United Kingdom, but the United States is right up there. So we're seeing an increase. Usually what happens in the UK is several weeks ahead of what's going to happen in the US, and that's another thing for us to look at. Hospital admissions are rising across Europe and the US as COVID-19 variants drive the infection, but resulting illness is less likely to be severe or cause death than in previous ways, according to data that we've seen. And this actually comes from the Financial Times and health experts. The rate of increased hospitalization admissions in the US is currently slower than in Europe. It's at 6%. This reflects the decline of the BA2 variant in the US and Financial Times data analysis. But as BA5 variant becomes dominant, the growth will accelerate. BA4 and 5 currently make up more than a half of all infections in the US that we've recently been talking about. But there is a new subvariant. So just when you think you've seen the worst, something else pops up. And it's been constant with this since we first started. A new Omicron subvariant, which is BA2, so it's on the same genetic path, 2.75, which is the current cause of concern at a global level and has already entered over 12 countries, including India and the United States. Omicron, which has driven most of the global surges since the beginning of the year, is continuously mutating. As of now, there are no new variants of coronavirus, but several subvariants. So we don't have variants of concern, though we do have these subvariants, which don't cause serious illness or hospitalization, but are causing infection that can have consequences down the road. The WHO is currently tracking whether the BA2.75 subvariant has properties of being more clinically severe or immunity invasive. As of now, experts believe that the BA2.75 lineage has not been documented to have enhanced severity or disease spread. So that's good news. The U.S. Department, so this is something, a lot of people didn't want to get these mRNA vaccines. And when I first started talking about this a few years ago, actually it's been a few years ago it seems, people were thinking this mRNA was brand new, although it had been in research for 10 to 12 years. It's actually being looked at all sorts of other things now, including a vaccine for HIV, but people were very hesitant about using what they considered to be a new vaccine, these mRNA vaccines. So any day now, and it could happen by the time on Friday, when we'll have this online. The U.S. Department of Health and Human Services, in collaboration with the Department of Defense, announced it has secured 3.2 million doses of Novavax COVID-19 vaccine. It is a protein-based adjuvant vaccine that's made available free to states, jurisdictions, federal pharmacy partners, and federally qualified health centers once it receives the FDA emergency use authorization and recommendation from the CDC. The latest vaccine would offer people a different choice, another choice to help protect themselves from severe disease and hospitalization due to COVID-19. So this is a more traditional vaccine, sort of like a flu vaccine, things that we've used. It's a protein-based vaccine, and it will take 2 doses to be fully vaccinated, and that should be coming available really soon. The Food and Drug Administration added pharmacists to the list of healthcare professionals who are allowed to prescribe Pfizer's pills for treating COVID-19. The move was aimed at making it easier for patients to get the drug and significantly ease the number of providers who can order the treatment known as Paxlovid. And it's a 5-day treatment. I believe it's twice a day. It does work, but you might have heard about, and so if you're within 5 days, I would highly recommend that you get this. There have been a few cases of what we call Paxlovid rebound. Again, Dr. Fauci got rebound, but I heard him on an interview this morning, and he said he really does believe by feeling up to date with his vaccines, even though he did get the virus and then get a rebound, which was worse after Paxlovid, he had what was considered mild disease, and he is, I believe, close to 80 years old or older. So again, the whole idea is that there are 300,000 licensed pharmacists across the U.S. It can get to people who are in medical deserts where they don't have a lot of primary care providers. Previously, only physicians, nurse practitioners, and physician assistants were allowed to prescribe treatment. I had an interesting text from a colleague. Could they write Paxlovid as a dentist? And to my knowledge, that is not in our scope of service. And what I did say was call up a pharmacy and see which pharmacists are dispensing this. We're not in a position where we are writing this yet. We'll see what happens in the future. And if we are writing it, I'll let you know. But I think it does cause a certain level of vulnerability to the practice, because you really need to know about what medications are somebody on, possible drug interactions. We already know medical history, but this does have significant drug interactions. So just by having the physicians, NPs, and PAs prescribing treatment, it was a restriction that often forced patients to scramble to find somebody who could actually write it, which I think is why this colleague sent me this text over the weekend. Would I end up in front of the Georgia board? And my advice was, please just call a pharmacy and see which pharmacy is dispensing. I think that is the way that we're going for now. The FDA said that COVID patients seeking a prescription for the pills from a pharmacist should bring records of their recent blood tests, a list of all of the other medications they take, of course, unless they get their medications filled at that pharmacy. The pharmacist should then review the records for potential kidney and liver problems or problematic interactions with the patient's medications and Paxlovid. A component of Pfizer's treatment can interfere with certain medications, including common ones for cholesterol and cardiovascular issues, potentially causing serious side effects. Another reason that we can leave this up to our medical colleagues and pharmacists. We were great at doing vaccines. If things change and we're allowed to write for Paxlovid, and I think that would depend on which state you are, of course, we will report it next month during our next month's webinar. But let's talk about long COVID. And this is an international cohort, COVID, 7 months of symptoms and their impact. A significant number of patients with COVID-19 experience prolonged symptoms known as long COVID. Few symptomatic studies have investigated the population in outpatient settings, hence relatively little is known about the symptom makeup, the severity, the expected clinical course, the impact on daily function, and return to baseline health. So this study conducted an online survey of people with suspected and confirmed COVID-19, distributed via COVID-19 support groups. And there are several that are out there. I actually don't have it, but I do monitor one for people with HIV and long COVID, just so I know what to expect to see in my patient population. They also looked at social media. Data were collected from September 6, 2020 to November 25th, 2020. They analyzed responses from 3,662 participants with confirmed diagnostic and antibody positive or suspected, diagnostic or antibody negative, and untested. COVID-19 from 56 countries with illness lasting over 28 days and onset prior to June 2020. They estimate the prevalence of 203 symptoms, 10 organ systems, and traced 66 symptoms over 7 months. We measured the impact on life, work, and return to baseline health. For the majority of respondents, greater than 91%, the time to recover exceeded 35 weeks. We really don't want to get long COVID. During their illness, participants experienced an average of 56%, 56 plus or minus 25 symptoms across an average of 9.1 organ symptoms. The most frequent symptoms after 6 months were fatigue, post-exertional malaise, and cognitive dysfunction, or we were calling it brain fog earlier. Symptoms varied in the prevalence over time, and we identified 3 symptom clusters, each with a characteristic temporal profile. 89% of the participants experienced relapses, primarily triggered by exercise, physical or mental activity, and stress. Stress causes a lot of things for a lot of people. About 87% of unrecovered respondents were experiencing fatigue at the time of service, compared to 44.7% of recovered respondents. 1,700 respondents required a reduced work schedule compared to pre-illness, with an additional 839 were not working at the time of survey due to illness. Cognitive dysfunction or memory issues were common across all age groups, except for loss of taste and smell. The prevalence and trajectory of all symptoms were similar between groups with confirmed and suspected COVID-19. So there are a lot of symptoms, but it really comes down to being exhausted, having mental acuity, not being able to respond well after having exercise or stress, or by physical or mental activity. So it is something serious, it's something real, and something that we need to be not casual about. Oh, I got COVID. Yes, I stayed home for more than 5 days. When I had a negative test, I went back to work. Everything was okay, but I just seemed to be tired all the time. I had a hard time concentrating. Those are things that you might hear, and we're really looking to see what treatments or what is out there to help manage this syndrome. Patients with long COVID report prolonged multi-system involvement and significant disability. By 7 months, many patients have not yet recovered, mainly from systemic and neurological cognitive symptoms, and have not returned to previous levels of work and continue to experience significant symptom burden. So long COVID is not something to be taken lightly. Even before this study, several studies have confirmed the presence of persistent symptoms following acute infection. Most recently, a large study conducted within the United States VA healthcare system found that patients with acute COVID-19 experienced higher rates of morbidity and mortality over the ensuing 6 months following diagnosis compared to uninfected individuals. The study and many preceding it used administrative databases and IC-10 codes to identify and categorize these sequelae, which may have inadvertently simplified the complexity of long COVID patient experience and missed details that can be captured through direct patient assessment. So it actually can be captured through direct patient assessment. U.S. scientists, though, are going to enroll 40,000 patients in a high-stakes $1.2 billion study of long COVID. So this time we're finally actually trying to meet the need of our patient population, finding out what is happening, what is causing patients to have these symptoms for such a long period of time. So the U.S. government is rolling out this massive study of long COVID in an effort to understand why so many body systems, why so many sources, why many people are having this go on. The study, which is named RECOVER, aims to complete enrollment of 40,000 people by the end of the year. NIH also plans to launch clinical trials on potential treatments in coming months. So if you have family members, you have patients, there is research being done that have long COVID. There's research being done now to see what we can do to improve quality of life and to hopefully prevent this in the future and to manage it while people have it. Scientists, physicians, and public health officials are worried millions of Americans may have long-term health complications from COVID-19. So again, this is actually a really serious disease and something that we shouldn't play with. So what about the oral cavity? I sort of not mentioned this, and this is a bit of an admission here. Early on in 2020, one of the people I do research with, she's a doctorate of nurse practitioner. She said, her kids were showing up with some weird oral lesions after they tested positive. Some kids in the neighborhood were having sores on their lips. There were people showing up with sores on the roof of their mouth. So, of course, I called up some oral pathologists that I'm friends with. Is there any kind of relationship between some of these oral lesions that we're seeing and COVID-19? Is COVID-19 actually causing these oral lesions, or is it some kind of sequelae that are causing these oral lesions? So the most commonly involved sites have been reported to be the tongue, the palate, lips, gingiva, and buccal mucosa. I'm not exactly sure what that leaves out. It is unclear as to whether oral lesions described are manifestations of COVID-19 or the results of immunosuppression and the side effects of treatment. It's well established that various types of oral lesions are manifestations of several other viral illness, so it's plausible that lesions can also be caused by the SARS-CoV-2 virus. So again, these are some of the lesions that we see. Ulcerative lesions, they can be aphthous-like ulcerations, herpetic stomatitis, nonspecific ulcers. It can be tongue changes, geographic tongue, red or swollen tongue, strawberry tongue, fissured tongue, etc. Bleeding lesions, and we'll go through them all: gingival lesions, necrotizing ulcerative gingivitis, papillary hyperplasia, candidal lesions such as pseudomembranous candidiasis and erythematous candidiasis, oral lichen plug lesions, oral anathema lesions, nonspecific blisters, mucositis. So it's basically a risk of almost every soft tissue lesion that we see can be seen in this patient population. But, and this is, I wish I had Michael Glick's slide on this, because he's able to click a button and say, and switch the language around. Are these lesions casual? Are they something that just happens to occur? Or are they causal? Is SARS-CoV-2 causing these lesions, or are they just a sequelae of having a viral disease that causes immunosuppression in certain patients? And the answer is we actually don't know. But again, when we do our oral exams at every visit, we need to ask our patients. We need to look. Our eyes are the best thing that we have. Our magnified eyes are even better, to check the oral soft tissues to see if you have any lesions. Management and recognition involves the expertise of us. It involves the dental community. Our medical colleagues are great from the chin down and from the nose up, but we're needed to manage these oral lesions. And as always, we're a remarkably important component of primary care. So we truly have covered a lot of information today. We've gone over how the variant of BA5 and 4 are causing most of the infections. It's highly transmissible. There are certain states that are really being hit hard, but if you look at transmission levels, it is all over the United States. The good bottom line is, as far as the initial illness, it tends to be milder. It's not, especially if you've been vaccinated and you're up to date with your vaccines. We've gone over who should get boosted and when they should get boosted. And please take precautions. And the other thing is, well, we know that they're working on some Omicron specific B4, B5 vaccine boosters. Should you wait for that to occur? Well, we don't know when they're going to come to market. It could be late December or early January when these newer, more up-to-date vaccine boosters become available. So right now, since we're in July, it's important that if you qualify, if you're over 50, if you're immunocompromised, please stay up to date with your vaccine so you can avoid getting serious illness, because serious illness is really linked to more to long COVID than just getting a mild illness. that might keep you at home because you're infectious, might make you not feel so hot for a few days, might keep you in bed or whatever, but you will recover. You'll come back to the workforce. And this is advice that I really want you to understand so you can share it with our patients. So if they have had COVID and they have long COVID, we can talk to them. I'm part of this one group, and one of the best activists in HIV and smartest activists that I have known over the course of my career. Her ability to remember things is remarkably reduced. You can see her struggling to breathe. And we don't want that for our families. We don't want that for our staff. We don't want that for our patients. What we want is the safest dental visit. We want to stay healthy and stay that way. So with that being said, there is another lecture this month on HIV and oral health. It's a live complimentary CE event on July 28th. It'll start at 8 p.m. Please register for it. I'm sure that you'll get information on how to register for this HIV oral health. Part 1 is already in existence. It's on YouTube. We'll get that information to you as well. Part 2 is going to cover what a lot of people are always interested in, the oral manifestations that we see in association with HIV disease. With that being said, I want to thank everyone for joining us. It's an honor to have been able to present this information to you at this point, almost 2.5 years. And so we're all staying up to date on COVID-19 and dentistry. We're taking all the precautions that we have taken since the beginning. We are asking if they've had COVID in the past. We're treating everybody as if they have an airborne disease, but we in the dental community are doing the right thing. In the building that I worked, I talk about we've had a couple outbreaks in the building where I work. The Oral Health Center, knock on wood, has had no cases of COVID, and we'd like to keep it that way. Again, thank you for your time and attention, and I'll turn it back to Gary. Our next session will be in August.
Thank you, Dr. Reznik, for your continual updates, and thank you for watching. Please email us any concerns, questions, or ideas for future episodes at webinars@henryschein.com. And please subscribe to the YouTube channel by clicking the subscribe button below. And to be notified of any new premieres, click the bell icon. Thank you once again. Please stay safe and stay informed.